Welcome to the fifth webinar in our Better Care Everywhere program series. I'm Anne Duggan, Clinical Director of Healthcare Variation at the Australian Commission on Safety and Quality in Healthcare. In the spirit of reconciliation, the Commission acknowledges the traditional custodians of country across Australia and their connections to land, sea and community. We pay our respect to elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islanders today. Thank you for joining us today. I think it's going to be a fantastic session. We've got the two Cathys, Cathy Balding and Cathy Jones. They'll be probably well known to you as experts in the area, and you've probably been listening to their podcasts, No Harm Done, which are always riveting and very practical. Well, today's a big day. It's the first time we get to see the faces behind those very familiar voices. They're going to talk about vanishing variation and give really good advice and practical tips. So I think the time will be well spent, and I hope you contribute. At the top of your screens, there's some icons. P is for purple, for participants to post questions and comments for the two Cathys. They've agreed to answer your questions and comments throughout the session, and also to answer them more fully in the question and answer session that follows. Just remember though, if you ask a question, try and put it into context so they know what your question was about or what your comment's about. Now, there's a few other icons for you to know about. If you have problems with your system, refresh using the green. If you have ongoing problems, then ring red back on 1800 733 416. There's a yellow icon where we'll send messages to audience, and there's the red icon to exit. I can't imagine you want to do that unless there's a cardiac arrest or some sort of emergency that would take you away from what I think is going to be a fantastic session. So for those who don't know, who are the two Cathys, or as they like to say, Balding and Jones, just to make it easier? Cathy Balding is the Director of Qualityworks, a consultancy dedicated to making quality make sense in health, aged care and community services. For more than 3 decades, she's worked in healthcare quality and executive roles in rural and metropolitan hospitals, in state health departments and on boards of a large aged care provider, and worked as an accreditation surveyor. Cathy Jones is equally well qualified. She's a Chief Quality Officer for TLC Healthcare now, having recently moved from being the National Director of Clinical Governance for Healthscope. Cathy started life as a speech pathologist. She's worked in public and private healthcare. She lectures internationally on healthcare quality, and she's currently a very active member of a health service board. So let's hear from Cathy and Cathy as they bring their trademark practical lens to all things healthcare variation. And don't forget, use the purple bar and participate. Ask any question. All questions are welcome, and if we can't answer them during the session, we'll make sure that you get answers after the session. So over to you, Cathy and Cathy.
Welcome to No Harm Done, a podcast about improving, exploring, understanding and getting on with healthcare safety and quality.
You are here with your hosts, Cathy Balding and Cathy Jones. It's Balding and Jones, and this is episode 30 of our monthly podcast series, the Big 3-0 Jones. And may I say also, Jones, it's nice to see you rather than just hear you.
Indeed, it is wonderful to see you on the video, Balding. Now, the No Harm Done podcast is designed to give people tips and present the latest research about safety and quality. And usually we present an audio version, but today is a special video cast as part of the Commission's online program series, Better Care Everywhere, Healthcare Variation in Practice. And basically, it's a conference held online and kind of on demand. It's like Netflix for conferences, Balding.
Now, which I love, Jones. That's great.
The theme of this online series is, of course, reducing variation. So we're starting with a variation to our normal podcasting only audio format. Is that wise, Balding?
Oh, well, Jones, it is an unproven intervention, I have to say. But in this case, I believe it's a warranted one.
Yeah.
And if you're listening in the future in a more conventional way, the idea is that it will hold up as an audio podcast as well. But we'll let our lovely listeners be the judge of that, Jones. And to really get into the spirit of things, we've done our best to minimise unwarranted variation between ourselves. You'll note, Jones, there's no variation in our first names.
No.
And I guess having different surnames is warranted, otherwise it would be pretty confusing. And our No Harm Done music clips also demonstrate warranted variation as well. All the music, as people may or may not hear, are variations on a theme.
And if you like, listeners and viewers can let us know in the chat which of Balding's musical numbers is their favourite, because of course she recorded them all. Now, unlike a classic conference talking head format, this is an interactive session. And by that I mean the two of us are going to be interacting with each other in our normal kind of irreverent fashion, Balding. But if you are out there watching us live on February 16 and you would like to interact too, feel free to make some comments or ask questions in the chat as we go. It's magic, Balding. And if you happen to be a new No Harm Done listener or viewer and you're interested in our previous 29 episodes, you can go to the App Store or the Play Store and subscribe in the No Harm Done podcast feed. And also, all the references we discussed today, they'll be listed in the podcast show notes on the No Harm Done website as well. Now, that's enough intro. Let's move on to our quality quandary. The quality quandary is a big issue we unpack, we argue about, and where we talk about conflicting perspectives, and we help people try and think about kind of what you're doing and why, and even how to do things differently. So today our quality quandary is vanishing variation, practical tips for doing more of the same. So what we're talking about is variation in clinical practice, Balding, and at its most basic, kind of from a consumer perspective, this is when we have people seeking healthcare, for example, having a baby, sore throat, breaking a hip, hopefully not all three at once, Balding. And those people are getting different treatment to other people who have exactly the same condition.
Exactly, Joan. So what we're talking about is care practice that varies from best practice or evidence-based practice or consensus practice. So these sorts of variations can occur in many different ways, between clinicians, within a department or a service, between clinical departments or between organisations, between geographical areas, as the Commission's Atlas series shows us so well, but more of that later.
Yeah, and although I think some people immediately think about treatment from doctors, you know, tests, prescribing, when we're discussing this variation, we're not just talking about medicos, are we? So there's many examples of multidisciplinary care variation as well. For example, if you have a stroke, being admitted to a stroke unit means a greater likelihood of discharge home and a lower mortality compared to admission to a general ward.
Yeah, exactly, Jones. And of course, variation isn't limited to healthcare. It occurs in other industries too. Has anyone who's ever hired a plumber or put their car in for a service would certainly know. And for me, Jones, as you know, I used to stay pre-2020, and I guess I will be again in 2021, in lots of motels and hotels for work. And to me, our unwarranted variation can be as simple as, in the same motel chain, different levels of cleanliness, for example. And that's, to me, very much unwarranted variation. But warranted variation is when I asked to check in early at one of those motels in that chain and they accommodate me. So you can
which motels are they, Balding? I want to stay in some of those hotels.
Well, Jones, 2021 beckons.
Now, fun fact, when you Google unwarranted variation, though, you don't get motels. You only get healthcare hits.
Yeah, isn't that interesting, Jones?
Yeah.
And, of course, other industries call it uncontrolled variation, I believe. And, of course, every human service sector has practice variation. It's not limited to acute. It's also primary care and aged care and mental health, and some of it's warranted and some of it's not warranted. And, you know, I like to think that, Jones, as if care was delivered by robots, and those robots did everything in a best practice way all the time with no variation. So you'd think that care and outcomes would be perfect, right? But of course, it's not that simple. And if it were, we'd have it nailed by now, probably. Because, of course, sometimes human beings need tailored care that doesn't fit the mould to get the best outcomes. Or there might be a choice between two care pathways that appear to get you to the same place. So that's warranted variation. And also, that's why clinical care is still delivered by smart human beings and not robots. Well, not yet, anyway.
Imagine Balding being the quality manager on the Enterprise or the Starship Discovery. Anyway, so what types of variation are warranted? So warranted variation in personalised or precision type medicine, you know, warranted variation can be a really good thing. So some chemo for melanoma only works, you know, with certain gene mutations, etc. So, and also consumer-centred variation is really great. We want that. So sometimes it's personal preference and sometimes, you know, variation's required to meet some unique clinical need or combination of different illnesses, yeah.
Yeah, exactly. So what we're really trying to do is reduce the negative or unwarranted variation that can't be accounted for by what the consumer needs or wants.
Yeah, so we're mostly talking about variation from best practice. And if we're talking about variation on a larger scale, sometimes it's only one geographical region that varies or is notably worse than others. So another example, opioid prescription, so morphine type drugs. Dispensing rates up to 5 times higher in some regional areas than in major cities, and also higher in areas with socioeconomic advantage. And of course, the research shows harm from this, you know, lack of effectiveness. And that's some regions, but also equally, Balding, it's quite frightening that sometimes it's every state and territory. So, for example, caesarean rates that are too high, you know, and then in other cases, it's the extremes that are the problem. So antibiotic prescription, you definitely don't want it to be too high. That creates all sorts of problems for resistance. But equally, you don't want it to be 0 or too low so that people aren't treated appropriately for their ear infection or whatever.
Yeah, exactly. And variation might not just be in the way a treatment is applied. It can also mean not getting a treatment or getting it when you don't need to. So, for example, the Commission's Atlas series shows that there's overuse of colonoscopy in some parts of the population and underuse in others. So this exposes some people to unnecessary risk from the procedure and others to potential harm because they needed it, but they didn't get it.
Yeah, so the variation here is not how much or how it gets done, but who gets it. More examples, bowel cancer screening rates are too low in some areas. Of course, Aboriginal and Torres Strait Islanders have low rates of things like cataract surgery despite higher rates of cataracts.
So everyone, you can have a look at the Commission's Atlas series and their website for some really good examples and plenty of them.
Yeah, and there's more than one atlas. It is a series because variation hotspots change over time. So like a regulation atlas where, I don't know, Burma changes to Myanmar or Ceylon to Sri Lanka. So variation hotspots do change, and the latest atlas is the one to have a look at as well. So a little teaser for you, Balding, for later in our presentation. Reducing variation is basically all about change management. So if you can identify your variation, the next step is trying to change it, of course, and we'll look at this later on. But we're not talking about something new here, it's just a new focus. So quality improvement principles, you know, apply to every change, every improvement, and reducing unwarranted variation can be done using your normal quality improvement cycle. So our focus today will be on how to use the wonderful guidance that we have in places like the Commission's Atlas series, the user guide, and in all sorts of other published research as well, which we will take you through. Now, Balding, how does vanishing variation fit within our overall clinical governance system?
Well, James, I thought you'd never ask. Now, as everybody out there knows, clinical governance is really, at its essence, about supporting staff to achieve great care and great outcomes. So spotting variation in practice that has a negative impact on care and outcomes should already really be part of any quality improvement program within your clinical governance framework. So in a clinical governance system, we look at our measures and we ask, are we doing the right things? Are we getting the right results? And those right results might be compared to internal data, trended data over time, comparisons between clinicians and services, or compared to external data. And if we're not getting the right results, Jones, well, we have to ask what influences that. So sometimes it's the result of human error. Sometimes it's poor systems or bad communication or equipment failures that lead to suboptimal care. And sometimes, Jones, it's because we're not doing the right things. That is, there's variation from best practice. And worse, there's unwarranted variation from best practice. So if your quality system is centred around achieving quality dimensions or quality goals for your consumers, it's quite easy to see where variation sits. It's in the appropriateness domain. And unwarranted variation in practice may lead to inappropriate care, which may then lead to ineffective care as it has an impact on consumer outcomes. But it can equally cause unsafe care or a lack of person-centred care if, say, consumer preferences aren't taken into account. So basically, Jones, I always think that doing the right thing is our starting point for creating consistently good care. So that's all well and good, Jones, but where do people start? Well, you can do it in all sorts of ways, and we'll explore them and identify them as we go through the how to get started list. But one way is to tackle the issue head on, to be proactive and go out there and identify your unwarranted variation. So you might start with a treatment or a procedure in your organisation that's high volume or high risk or high cost, or all three preferably, where you're not getting the results you want. Because unwarranted variation in any of these areas is probably affecting a lot of people, causing harm and costing you a bomb. And Jones, interestingly, I remember writing these three criteria for selecting areas for quality improvement in a newsletter in the 1980s, which some of our listeners will not remember, Jones. So last century.
Wow. What goes around comes around. It's the old wine in new bottles, I think.
That's right, Jones. Might be slightly more sophisticated in the 2020s, I think, in the 1980s. But we kind of got it in those days. We just mightn't have known what to do with it.
Yeah.
So identifying where to start is something the Commission's Atlas series can help you with, and from a proactive approach. They've already done the hard work of sorting out which clinical practices have a lot of variation, and you could start with drilling down into one of those that relates to your service. So, for example, if you're a health service that admits patients for colonoscopies, the Atlas gives some great information and prompts for how to spot unwarranted variation.
So to answer, the question of where it fits into your clinical governance system, I guess it depends on, what headings or snappy diagram you're using for your clinical governance system, but there needs to be reference to monitoring appropriateness of care, effectiveness of care somewhere in your framework. And of course, this links to criteria or action 1.27 and 1.28 of the National Safety and Quality Health Service Standards. So 1.27, and I'm summarising here, is all about supporting clinicians to use best practice guidelines and tools and the best available evidence for clinical care. And then 1.28 being the key one really, which is systems to monitor the variation, compare externally and inform clinicians when you find it, and to fix it. And I think the key here is, we would think we're monitoring variation, but is it systematic? Do we have a system there built in to do it? Which leads us to, of course, something I'm very happy about, data. So this leads us to
Jones.
Data, Balding.
Yes, all right. And here's the bit that's just for you, Jones. What data helps us to spot practice variation? So we've already said internal monitoring data is a good place to start. You're already doing tons of audits. You've got clinical registry data, probably in the bigger organisations. You've got comparative data from external sources. You've got your clinical risk register. There might be some risks there that are sort of stubbornly refusing to shift with all of your controls and despite all your hard work. And you could look at practice variation as a cause of why those clinical risks aren't shifting.
Yeah. And as well as looking sort of internally, you've got your external data from the Atlas series and the website. Health department portals will help you with this as well, clinical indicator benchmarking and so on. Now, sometimes, though, it's not the aggregated data that tells you you've got a problem, but you get some kind of surprise through a critical incident that shows, oh, surprise, surprise, best practice wasn't followed in this one occasion with catastrophic results. Now, it could just be a one-off, or you might delve further and uncover, this deviation or workaround is just the norm. And, the fact we haven't had more critical incidents in this area is just luck, or staff have been heading it off at the pass.
Yeah, exactly, Joan. So our monitoring and our sentinel events and our incidents can all help us to identify areas of unwarranted variation as the cause of the harm. Now, of course, you can't leap to conclusions that all harm is now based on unwarranted variation. Clearly.
Oh, isn't it that easy?
Well, we tend to do that, Jones, don't we? The pendulum swings, so we don't want to be jumping at shadows. Don't assume that it's at the core of everything. We need to drill down and find out, of course, and do our good problem diagnosis as we would with any improvement. There's another way, Jones, that some organisations are doing it, and I know that Nicole Rasmussen from Alfred Health, who's part of this series later in the schedule, will talk about their evidence-based review committee, where clinicians refer practice that they think may not be following the latest evidence, perhaps hasn't kept up, or perhaps where the evidence is unclear. And apparently that's a very successful, safe space for really robust discussion and sort of grappling with these really interesting topics and has had quite a lot of effectiveness in changing practice. So I really look forward to Nicole talking about that.
That's great. And that's, putting a structure in place. It's like what we were saying before. We think we're looking at variation. We've left it up to the clinicians, but now we're systemising it. We're putting a structure in place that can really make change happen. Now, this may all seem a bit overwhelming to everyone who's watching. Our mantra for today is really just start. Start with one. So it's like the Pareto principle, find one area where you have variation, pick that one, pick it today at the end of this session, find some evidence for it and do that one change well. And that will give everyone confidence for doing the next one and picking another one off.
Yeah, absolutely, Jones. And if you're really stuck with where to start after all of our wonderful suggestions, go and talk to your health information manager. They really do know what's going on with clinical outcomes and practice variation in your organisation. They may be, if you haven't asked them before, a really untapped source of wisdom there. They'll definitely be able to point you in the right direction for a place to start.
Yeah. So in a minute, we'll discuss the great user guide for how to fix variation in a systematic way. But the first question I always have, Balding, before we can fix any variation is asking, why? Why does variation even happen? Because I've known CEOs to say things like, oh, we know the best way. Why don't those naughty clinicians just follow it?
Well, indeed, Jones. Well, why do we have unwarranted variation? Well, that's a very good question, isn't it? That you will now answer for us, Jones.
Oh, yeah, okay. Well, I mean, we know that changing practice of many years is really, really hard. So let's use a couple of examples, Balding, to illustrate. Now, first one I've picked out is a personal example of why this is hard, and then we'll take one from the literature. So the first one I'm going to focus on is falls prevention. And a few years ago, some of my hospitals that I was working with, they had a falls risk assessment, everyone does, that was no longer kind of evidence-based. And some of the interventions, likewise, to prevent falls, they were also not evidence-based, in particular the non-slip socks. And why? Why does this happen? Well, the evidence changes. Evidence changes over time, and the forms don't necessarily keep up. And there's often, I found, there's lots of variation across dozens of hospitals. So this is pretty typical of what's out there in the world. So what did we do about it? So this is a real life example, Balding, and what we did to start with is we basically told everyone, we said, look, here's the latest evidence, we provided the information to the clinicians, and here's how you should do the new form, and that resulted in precisely no change at all, Balding. So,
well done, Joan. Excellent work.
So just on this topic of the non-slip socks, for example, we didn't stop using them in using them in the right way. In fact, the ordering went up. So people kind of saw the writing on the wall, and they decided they would order more non-slip socks for more occasions when they shouldn't have been using them. So change is not that simple. Why? I'm getting back to why. Clinicians don't want to be told that what they've been doing for years and years and years to keep patients safe is now wrong. You know, why did we do it for all that time? So, and also sometimes there's competing evidence. So in this case, there was an infection bit of evidence compared to the falls evidence with the socks. Some sites were using socks for different purposes, you know, to keep people's feet warm, for example, and some of the use was appropriate. So it's, of course, it's not that simple. So what do we do next? So in this particular example, we did some policy and some education. Now that, as we know, doesn't always work, Balding, the policy and the education. It is a weak control, and you do need to do it, but it isn't enough on its own, and there's often influence from other interested parties and other people. So finally, communicating your peer data, showing the variation. Here's the hospital where we use the socks the most. Here's the hospital we use the socks the least. Why is that variation there? And then finally, you know, a forcing function. So let's take it off the ordering list, and then no one will order them. So you can use all sorts of different reasons, depending on the why. You can use all sorts of different strategies. So
yeah. Great example.
That's one.
It's really fantastic. Yeah, and I'm sure lots of our listeners are nodding vigorously.
So that's a bit of a work in progress. But there's another wonderful example I found in the literature, and this was on elective caesarean sections prior to 39 weeks without a medical reason. So the Commission's website shows a lot more interventions of this type as well, but we shouldn't really be doing elective planned Caesars before 39 weeks without a medical reason. And if it's too high at your hospital, you know, what can you do about it? Well, you can present data to your clinicians, and that can often be, you know, a really useful way of doing it, as one research study did, and this research study is in the show notes as well, the reference. But what they did was they provided the education and information only, and that managed to decrease their use of this intervention by 40%. So the information only did something, and it wasn't statistically significant. So then they moved on to education plus what they call a soft stop, and this was monitoring the use and finding out if, you know, if the education plus the cases referred to peer review and a bit of public reporting would decrease this by more, and it did. So it decreased the elective planned Caesars before 39 weeks by 60%. So we've gone from 40% with just the education to 60%. And then finally, can we just put a hard stop in place? So we're just not taking bookings anymore, and they stopped the booking, which you would think would reduce it by 100%, but it didn't, Balding. Yes. It was 80%. So someone's clearly got around that control. But you can see there the hierarchy, and it's similar to what I talked about for the non-slip socks. You know, the education or information isn't enough on its own. A soft stop might help, providing the data, providing the peer support committee, and then the hard stop, if you have to, is the way to go.
Yeah, and they are two really fantastic examples, Jones. And I do admire your ability to say soft stop with such ease as well. It's not easy.
No.
So, no, really great examples. And I think that for a lot of people, that'll help clarify what we're talking about here, and also the challenges of doing something about it. So, is there a guide out there for everyone to follow? Well, yes, there is, Jones. Our Did Read, Do Read segment is just about to dive into a step-by-step guide to identifying unwarranted variation and what to do about it.
So this is our Doctor segment. Did read, do read, and in this segment we talk about anything that either Balding or I did read that you might have missed, and we suggest that you go ahead and read it too. Do read it. So on this topic there are several documents we'd recommend when it comes to variation, and this particular focus, I think you're going to tell us, Balding, what are we talking about here in our Doctor segment?
We are talking about none other than, Jones, the Commission's user guide for the review of clinical variation in healthcare from 2020. So it's very, very fresh, which we will refer to from now on as that user guide.
And this was written by the Australian Commission on Safety and Quality in Healthcare, as we said, with a focus on the national standards. And what I like about it, Balding, is 13 pages long, and 13 pages of examples. So that's what you've got to get through when you're reading it. Yeah. It's not hard, actually. Now, many of you may not have got around to reading it because it only came out about 6 months ago in August, so you are forgiven. But Balding, this is my favourite thing I've read this year.
Yeah. So the guide explains basically how health services can implement our Action 1.28 in Standard 1, Clinical Governance Standard. And of course, the intent of this action is that health service organisations use the data collected on clinical care to identify potentially unwarranted variation, as we've been talking about, and to regularly review and improve the appropriateness of clinical care. Now, you know, Jones, I'm excited about whenever a quality dimension gets a new lease on life, and so appropriateness and effectiveness, I guess hand in hand in this case, are really making a comeback, and I'm very happy about that. So you need to review your performance, as we've said, in comparison to other health services and or evidence-based guidelines or clinical care standards. So that's kind of the basis for your comparison.
So the user guide takes us through 6 steps to vanish variation, or as we said, unwarranted variation. And we're going to go through each of those 6 steps with an example. The example will be, we just pick case study 1 from the user guide, and this is on variation in discharge planning after stroke. So let's dive into step number 1. And step number 1, of course, is partly what we've been talking about already, is to select your clinical priority areas. So you don't have to pick everything, and what are you going to select? And as you mentioned before, Balding, it's often best to focus on the clinical areas of your highest preventable risk to patients or your greatest activity in your health service. Pick the areas where you've got available data already, clinical administrative data, and make sure you're getting input from your clinicians.
Yeah, absolutely, Jones. And we will explore the clinician input a little further later in this edition. But in this particular example from the user guide, so for this first step, the head of the stroke unit thought that discharge care planning should be made a priority for improvement because a patient was readmitted with a second stroke following discharge without the preventative medication they should have been discharged on. Now, Jones, you'll notice how handy it is that it's the head of unit here that initiated this. Clearly, that's way more likelihood of success, and a really good reminder. If you're targeting a certain clinical practice, don't dive in without those who lead and oversee that clinical practice involved sooner rather than later. But as I said, we'll talk a bit more about that sort of change and changing with clinicians later on.
Yeah, so engaging with clinicians, selecting the areas you'll have more engagement, and you're picking what your clinicians are most keen on, something a doctor's interested in pursuing.
Yeah, absolutely. And a lot of people out there might be thinking, I don't know what that is. Well, you need to have some conversations with people who will know what those clinicians are interested in if you can't feel that you can have them directly yourself. So definitely add this to our Where Do We Start list, Jones. Clinician interest is a great place to start. And I call this a Goldilocks clinical variation story, Jones, because a senior clinician is leading, they've got good data ready to go. It's not a really hot topic, not too hot, so no one wants to touch it. And it's really wading into a dangerous patch. It's not too cold, so no one's interested. It's just right. So a Goldilocks topic, Jones, I will add to our Where to Start list.
That's great. I like anyone who's brave enough to focus on a cold tub of porridge as well here.
We do though, Jones, don't we, in quality?
Yeah.
Way too much.
That's true. So step number 2, now you've selected your topic. The step 2 is identify how you're going to assess this variation. So for your area, you're going to identify what aspect of practice you're focusing on, where to access these evidence-based guidelines that you should be following. If you know that there's variation, what evidence are we supposed to be following, which clinical care standard or protocol, and then how to collect data to measure that variation. There's probably existing reports, the clinical quality audits, registries, etc. As we said before, your friendly health information manager can help you, or you might have to develop a specific audit, but hopefully you've got some data already. So how's our case study doing there, Balding?
Well, Jones, as luck would have it, in this case study, this hospital contributes to the Australian Stroke Clinical Registry, very handy. So no new data collection was needed to examine current practice. They already have the data, they have the benchmark, they have national and state data, all available for comparison. So hooray, Jones. And in this study, the clinical team chose 2 of the indicators from the Stroke Clinical Registry related to discharge care planning to really dive into, to look at what they felt was going wrong or not happening as it should be happening. So they chose care plan provided at discharge and discharged on an antihypertensive medicine.
And really important to remember, before you go ahead and develop your own thing, have a good look to see if the data already exists, because
absolutely.
Chances are it does exist, but no one's been looking at it, or, you know, if you don't know it exists, it's always worth going and having a look there. So now we're going to move into step 3. So step 3 is measuring what the variation is. So measuring your clinical variation and reviewing your performance, you need to put a process in place so you can see, you know, what care is delivered, what are we measuring at the level of the clinicians, the team, and or, you know, the whole organisation as well. So what's our performance? Then compare it to the available data, the data source we just found, making sure that we have the internal data matching or not matching the external data. And as we've said, we've got lots of places where we can compare, maybe with peer health service organisations as well. And then assess, you know, is it important? Is the variation important, and what action do we need to take? So what this example started with, I think, Balding, was they started with one example of something that went wrong, and then they found the variation was more general, wasn't it, for all the stroke patients?
Yeah, that's right, Joan. So in this case, the clinical nurse consultant generated a report from the Stroke Clinical Registry portal, once again, very handy to have, which showed that this hospital actually performed poorly in discharge care. They were below the state average and benchmarks for having a care plan and for discharging patients on the appropriate antihypertensive medication. So, Jones, we found the culprit. Variation from best practice.
Yeah, that's great. And again, you need a systematic way of looking at this, because the red flags may have been popping up for some time. But this case study really highlighted it too, which is great. So moving on to step 4, now you're exploring those reasons for variation. This is the detective work, you know, determining what the contributing factors are. Why are we getting it so wrong? Having a look at, are there any clinician factors or consumer factors or health system factors? Usually you'll find there's a system factor here, not an individual person factor, but often there's data factors too. So this is the why, isn't it, Balding?
This is the why, Jones. And in our Goldilocks stroke clinical variation story, an interdisciplinary team, including consumer, got together and brainstormed what they felt was contributing to the inconsistent discharge care planning practice. And they identified a lack of awareness of appropriate prescribing of that prevention medication. And they also identified that that wasn't helped, that lack of awareness wasn't helped by staff rotation through the unit. They identified a lack of a system to ensure that appropriate prescribing of the medication. So you've got different people coming through the unit and you haven't got a system to ensure that prescribing. So clearly you're going to have gaps. And also lack of an appropriate discharge care planning template to guide all this. So as you can see, Jones, the causes here are a mix of behaviour, which is caused by a lack of awareness, which is kind of supported by the staff rotation system and the systems for prescribing and discharge planning. So the systems, as you said, Jones, really aren't supporting that best practice and they're allowing that variation. So obviously these are some key reasons for unwarranted variation, but obviously there's lots of others, Jones. Can you enlighten us perhaps as to what some of the others might be while we're on reasons for variation?
Yeah, well, the user guide does give you a big list, but what was occurring to me there as you were talking, Balding, is that often it's, you know, this is where your fishbone diagram comes into play or your flow charting. So there's a lot of quality improvement tools for investigating why, what factors are involved. So as well as that, in the guide, I'll just highlight a couple of causes for potential variation. And one of them, we mentioned this before, that clinical care may not have changed in line with updated evidence. The evidence has changed. We're just not up to date with it. It is really hard to keep up to date with all those journals. No blame here, but let's just upskill and make sure we know that. So that's one useful cause. And another cause is it could just be differences in the clinician's knowledge or agreement. Now, the differences in clinicians' agreement may make this a too hot porridge topic, but it may not. It may just be that we can come to a consensus about the latest evidence relating to these procedures. The variability may just be due to not everyone agreeing, and we can get everyone on the same page. So that's a possibility. And there's a bunch of other reasons, but the other one I like is really the stroke unit is this example, the inadequate system support for appropriate care. You know, the form hasn't been updated yet. We don't have a system to make sure this happens every time. So I really like those particular examples, Balding.
Yep, great.
So that takes us to step number 5 is what we're up to.
Yes.
And step number 5 is, now that we know all these reasons, it's time to take some action. So let's improve the care. Let's embed and spread the changes within our entire health service. Take the action. This is the actual change, Balding. So how did our stroke unit do this?
Well, it's a good reminder, Jones, isn't it, this case study, that we so often just say, oh, I think we know what this problem is, let's just fix it. It tends to be a bit of a default position. But it's a great example in this case study that, no, first of all, you have to figure out what's really going on. Then you get to the action bit. So they designed a few changes to tackle the problem. And once again, that's a great reminder that it's very seldom just one thing that fixes anything. You kind of need a bundle. So they included discharge care planning and orientation of new staff. They changed the discharge planning template. They put the recommendations and the evidence for that prevention medication added to those bedside charts right where those decisions are being made as a reminder. Senior staff decided that they would discuss discharge care planning for stroke patients on ward rounds and lead some education sessions on the importance of it. And pharmacy staff were then going to alert medical teams if that prevention medication was not included at discharge. So you can see, Jones, here it really is a bundle, isn't it? It's a mix of reminders and double checking and leadership and system change. And that mix of methods is going to be more powerful than just one of those.
Yeah. And on the embed and spread side, I reckon, Balding, this is the point you realise that, you know, one doctor has embraced the change, but there's a few others that haven't. But as always, treat it as a quality improvement project. Always involve your consumers in this as well. We're not really talking about in-depth change management today, are we, Balding? It's a bit beyond what we have time for, but you can, if you want to, go back and refer to our podcasts on change. We've done a couple. I think it's episode 5, 12 and 28. So, and our...
Well done, Jones.
I prepared that one earlier. So, and our TLDR segment will also touch on this in a minute. So that takes us, we're almost to the end here of our user guide, where we're up to step 6. And step 6 is really important because that's recording and reporting activities to monitor this variation on an ongoing basis. So now that we think we've fixed it, this is the bit where we really have to evaluate, did it work? Has our variation reduced? And as always, you need to, you know, maintain your records of this review. You need to maintain them, particularly for action 1.28 if you're going through the national standards, but also make sure you're reporting this back to your clinical, your management, your board meetings, etc., etc. And then monitoring it. So if you think your performance is going to slide, can't monitor everything, but make sure it's a regular clinical indicator that you now measure, that you don't let those red flags pop up again, that you have some way of constantly checking that you are monitoring these on an ongoing basis.
Yeah, absolutely, Jones. It's such a good example right through, isn't it, of the quality cycle, because this is the bit that we often don't do or that drops off, that longer term monitoring to see, well, did we really make a difference or did we just put something in place and go on to the next thing? So our case study heroes here, of course, did exactly the right thing. And at 3 months and 6 months, they followed up and they had a look at the data. And they kept implementing new initiatives until they got to the national average. So they didn't give up. They tried different things. And then they moved beyond that with further work to chase the benchmark hospitals. So good on them. And of course, then they put it into their regular monitoring, exactly as you said, Jones. Their local results for the indicators from the registry are reviewed every quarter at a multidisciplinary stroke meeting. So they're keeping an eye on it.
So to sum up, go away and read this user guide, cover to cover, actually. It's really easy. It is a doctor. Do read, and we'll take you step by step. Now, let's move on, Balding, and let's talk about the consumer role in vanishing variation that is unwarranted. This is the point, the segment where we focus on patients and consumers and their perspectives and strategies to get consumers more involved in their own healthcare, because, Balding, consumers are the point of our entire quality endeavour. And today we're talking...
Jones.
Yep. And today we're talking about the consumer role in reducing variation. So how do we get consumers involved in this?
Well, Jones, we've already mentioned that warranted variation may relate to consumers' clinical needs and personal preferences. So my question, I guess, is how do we build that warranted variation into our care? And before people think, oh, that sounds really hard, well, it's kind of not new. It's part of building the role of consumers in our quality system. And gee, we've been doing that for an awfully long time now, both as partners in their own care and also in helping us to improve our systems and processes. So if you can see the variation as part of this process of consumer partnership, I think it becomes a little less kind of confronting and complicated. So we know that making decisions and choices about how care is delivered is absolutely key to consumer partnerships, right? And we can't do it without that. But to make it work, I reckon there's a couple of preconditions for success. So before you dive into this, have a look at the willingness of your clinicians to embrace consumers as partners in their care and also in helping us improve things more broadly. You know, we should already be working on cultivating that willingness as part of our quality system. But obviously the smart money is on first working with the clinicians who are already down the path of working with consumers as partners. You know, don't pick the clinicians that are still not quite on board with it. And the other thing I reckon is that giving those clinicians and consumers some common ground and language to meet on so they can work together on care variation. Now, you might think, well, Cathy, that's impossible, really. How do I do that? Well, there is some good news. We do have some common ground already in the form of what are called decision aids or support tools. Possibly not the most exciting title in the world for something that's actually really, really useful.
Yeah, so one of the best ways of involving consumers in vanishing variation is really to make sure that they have access to some of these decision support tools, right? How do they help, Balding?
Yeah, absolutely. Well, if you have a look at the Commission's website, they've got some great stuff on decision support tools. And, you know, they say basically what they do is bring together the really good evidence about particular conditions so that consumers and their clinicians can discuss those risks and benefits in a common language, in a common way, and explore the consumer's preferences and share those decisions about care. And that sounds really good to me, Jones, I have to say.
Yep. And we've dug out a couple of references on this to suggest where to start. So, but first up, we've got kind of an oldie but a goodie. So this particular article came from a little while ago, and it's from 2004. It's Modifying Unwarranted Variation in Healthcare, Shared Decision Making Using Patient Decision Aids by O'Connor et al. And they really highlight that, as you said, shared decision making is the process of interacting with patients, coming to an informed choice about healthcare when there's multiple options. So, and the various patients may view these options and value them differently. So that's the shared decision-making side. And then the patient decision aid is the actual tool or the evidence-based tool designed to facilitate the process. And typically, Balding, they're handouts or in some cases apps or electronic surveys or tools online. And they're usually, well, they need to be at a health literacy level targeted for consumers. And there's been a lot of randomised trials with decision aids, and they show things like they improve the quality of the decisions that are made by consumers. Consumers they're happier with the decisions that they make, and they prevent the overuse of less effective treatments. So this is overuse of less effective treatments. This is where, you know, there's a great potential role in reducing that unwarranted variation. Yeah.
Yes, Jones, absolutely. And they're generally beautifully crafted and beautifully done when you have a look at them. If you haven't already, people, I encourage you to go to the Commission's website and have a look at some, and you can source them from other places too. But it's really about that many decisions in healthcare about which way to go with a treatment or care process don't have exactly a right or wrong answer, because it's not that straightforward, right? As we said earlier, it's just not that simple. Sometimes it's 6 of one and half a dozen of the other in terms of the outcomes between 2 different pathways. Or different consumers will value one pathway in a different way because of their circumstances. So common examples include different options for treating, say, abnormal uterine bleeding, benign prostate enlargement, chronic back pain, early stage breast or prostate cancers. There are all sorts of options for treating these. And, Jones, when I was researching this, I was also thinking we might discover that some approaches to these conditions are not working for consumers through PROMs or PREMs, through patient-reported outcomes or patient-reported experience measures. They might tell us that, I'm on this pathway for my condition, but it's just not doing what I thought it would do. It's not suiting my lifestyle at all. Is there another way? So that's another place to start, Jones, with your PROMs and your PREMs if you are
PROMs. It's a great use of PROMs, isn't it? Yeah.
Isn't it? Yeah, yeah. It can really alert you to something from the consumer perspective. So I encourage people to go for it. Now, the good news, Jones, is that these patient decision aids absolutely work. And there's been systematic reviews done. And in this particular article that looked at this, it really did indicate very clearly that as part of discussions between the consumer and the clinician, of course, as you said, there's those really positive effects, including increased knowledge scores on the part of the consumer, improvements in the proportion of patients with those realistic perceptions of benefits and harms of a treatment or procedure. And really, how hard is that to get across, Joan? So if a decision aid can do that, that's spectacular, right? Those lowered scores for what they call decisional conflict, Jones, which means I'm not really sure if I get the whole picture here, but people feeling like they did get more of the picture and understood it way better. Reduced numbers of people who are undecided about the treatment choice after counselling, so people making decisions rather than just not being able to make up their mind. And more congruence between the treatment choice and the consumer's values, which to me, Jones, is where the gold is. And there were lots more positive effects as well, but they were just some of the main ones.
Now, sometimes there's only 2 choices, though, isn't there? It's either treatment or no treatment. And there's also the occasions where the consumer's choice doesn't support the evidence. So, what happens when you have a sore throat and you ask your doctor for antibiotics, and fortunately, we've got some good decision aid resources for those particular scenarios from the Commission. So we've had one article that we've talked about. For the second reference here, we'd like to refer you to the Commission's website. And it is there are several decision aids there on the website. When you go to the search bar on the Commission's website, just type decision aid into the search box. Is a good way of finding it. And typically these ones are 1 or 2 pages. They're really easy read for a consumer. And the first page is the most important information, and the second page is additional information. And 3 of these decision aids on the website relate to antibiotic use, which is a fabulous thing to get everyone more informed about. Middle ear, acute bronchitis and sore throat for the antibiotic use. And then there's one on osteoarthritis of the knee as well. So we're going to take people briefly through the sore throat decision aid, which is up on the screen now. And this one, Balding, starts with a question. And the question is, should I take antibiotics or not? So there's some basic information there. I like the way the heading is the question. Do you like that?
Yeah, Jones, I just like the way this is laid out generally. It's just so super clear and it just leads you through this really logical sort of thought process and it's so easy. So, yeah, I'm a fan.
Yeah, and it gives these 2 treatment options we mentioned before. This is basically you're either taking antibiotics or not taking antibiotics. They're your choices. Yeah. And it gives you the risks and benefits of each option. So when it gets down to the dots at the bottom of the screen there, the green dots show you that only 6 out of 100 people get better faster with antibiotics. So, faster within 3 days. It isn't that great. So that's not saying that antibiotics are particularly helpful there. So it's driving that point home. And then the red dots on the other side show you that 7 out of 100 people that take the antibiotics have side effects. So, you know, I'm persuaded I'm not going to ask for antibiotics when I next go for my sore throat. And then as you move on to page 2, which we don't have up on the screen there, but go and have a look. It goes on to give you the number of research studies that they looked at and what it's based on, and also a list of questions, Balding, to ask your doctor on this very topic.
Yeah, really, really nicely done, Jones. And I would definitely use this myself.
Have you been taking antibiotics for your sore throat? Are you in those 100 dots?
wouldn't dream of it, Jones. So I guess what we're saying here is that there's all sorts of ways to present this to doctors. One thing is not to just dump them and run. So we don't want, oh, look, here's a bunch of things you have to talk about with your consumer and run away. We really need to have those docs on board, understanding what this is all about, and seeing them as part of their consultation process, not some extra thing that someone's imposed on them, because just that's not going to fly.
Yeah. So if people are wondering where to start to get consumers more involved in Vanishing variation, print out these 4 decision aids and put them to work within your health service by giving them to patients. Now, that music would suggest this is the climax of our presentation today, when in fact it is the too long didn't read section. TLDR, where we pick a couple of articles that are longer or perhaps just harder to devote time to, a hard read perhaps. And we know your time's precious, and we don't always have time to read every article, but don't be guilty, we read this so that you wouldn't have to. So our article today that we've looked at, or a couple of articles, focus on change and how this relates to reducing variation practically. So it's one thing to identify the need for change, but quite another to make it happen. We'll refer you back to the podcast on change management, 5, 12 and 28. But before we get to the articles, Balding, do you like the cross-promotion to our previous episode?
I'm dumb with admiration, Jones. You can pluck that from the air.
Yeah. So before we get on to the articles, Balding, I just want to touch on resistance, which is perhaps my favourite part of change management. It's no one's favourite part, but being a massive contributor to variation is resistance to change. So research evidence changes and people just don't keep up with it. It's really hard to keep up with. And as we said earlier, if people have been doing a specific practice for years, they don't like to think that they were getting it wrong all that time. So there will be resistance. So thing to say about this is expect it, embrace the resistance, because if you don't get resistance, you're probably not changing anything worthwhile.
Love the resistance, Jones. That may be the key message. Yeah. This whole session.
Yeah.
Well, Jones, and the other thing that I find, and it actually took me quite a few years to realise this, you know, I'm quite a slow learner, that resistance often comes from addressing change first as a process and then kind of hoping people follow the process change along. And we know that just doesn't work, you know. You'll get way better results with less teeth grinding if you put the people before the procedure. So start with the people who have to enact that process and work with that process. And don't forget that clinicians are people too, Jones. So I always think when we think about any sort of change, but, you know, particularly the change we're talking about today, you know, first check your attitude. You know, changing behaviour is really not a great way to think about it, because it kind of hints that the current behaviour is wrong, and that sets up a mindset, and that's not going to be a good platform for collaborative change, because it might shine through, you know, even subconsciously, Jones. Yeah. So what we really want to do is support clinicians to give the best care they can, so that consumers can get the best care they can, you know. So let's just look at it through a really positive lens. And you've heard me say this before, Jones, probably in those 3 change episodes that you've referred to, that information drives understanding, but feelings drive action. And anger is a feeling, Jones, you know, and that's going to drive an action you don't want, such as digging in and saying, well, I'm not changing, I don't care what you say. So resist the temptation to charge in, boots and all, and really annoy the people that you're going to have to work with. And I have been guilty of that many times in my career, Jones. Now, wanting is also a feeling. So think about tapping into clinicians wanting to do good for their patients, wanting to be the best, wanting to do research, all the things that they want to do. So, you know, instead of this is how you're doing it wrong, ask, well, how can we support you to get the results you want and that look good next to everyone else's results, because that's also a wanting that we all want, and so that our consumers and our organisation can all get what we need as well. And I've got an article here, Jones, when I was looking into this, that, as you said, maybe more too hard didn't read than too long didn't read. It's got some really great stuff in it about promoting behaviour change, which is probably better than changing clinician behaviour. But I had to read this one 3 times, Jones, to get the gold. But it was well worth it, and I read it so our lovely listeners and watchers don't have to.
And in fact, you read it so that I didn't have to, Paul.
Yes, that's correct. I wasn't going to say.
Thank you.
Well, I did. I took one for the team, Jones. So this is called Promoting Professional Behaviour Change in Healthcare. What interventions work and why? A theory-led overview of systematic reviews. Ooh. Now, a theory-led overview of systematic reviews, Jones, is only catchy for a certain cohort of our listeners. I understand that. But you know how I love a systematic review, because when you can kind of unpack the often quite dense material, there's generally some great stuff in there, and there is in here. So I just want to highlight a few findings from this. So they were looking at that behaviour change of clinicians, and these are some of the key things that they found. First of all, interventions based on action, such as audit and feedback and reminders, and education, tended to successfully change professional behaviour, wait for it, Jones, more than those based on persuasion by opinion leaders. Wow.
It really works because it's appealing to why the behaviour change was necessary, not just telling people how they had to change it, for example.
Yeah. Or you have to do it for accreditation, just stop it, people. If that's one of your reasons for change, stop it. Never let that pass your lips again. Because that you'll never get these positive responses if you say we have to do it for accreditation. It's got to have meaning for people. And I don't think that's hard when we're talking about variation, because it's inherently interesting. Well, I think so. And I think clinicians are inherently interested in their practice and
far more interested in this than a medical record audit. Like this is actually, this is my actual work and the outcomes. It's fabulous.
Yeah, totally right. And so people don't kill it by making it dull. Tap into people's curiosity. People have curiosity about their practice and outcomes. And, why am I getting different results? Why are consumers having different experiences when being treated for this condition by me than by someone else? And the third thing I wanted to highlight is that the article found that bundles of interventions packaged together seem more effective than single interventions. And we have mentioned this a couple of times already. But interestingly, not because it's a cumulative effect, which is kind of what I thought, but because bundles of interventions tend to form what they call social systems. I guess if you have different interventions, you're tapping into perhaps different people, and perhaps you're tapping into different parts of the process or treatment that you're looking at. And it gets that kind of social perspective on the change that people are talking about it in corridors, And we have talked about social change in our change podcasts in the past, Joan. So it's really those formal social systems that promote changes in behaviour norms.
Yeah, they reinforce each other with that sort of social network too, which is the best way of making change happen, not by a hierarchical approach, but all of the social systems working together in order to reinforce each other. Yeah, it's great.
Yeah, exactly. So it's not just education or data or meaning or social systems or getting your formal systems right, as we saw in the case study. It's all of them wrapped up into a big bow of the way that clinicians work together and do their work. And that spreads it amongst colleagues through the conversations and watching what others are doing and getting the feedback on how things are progressing. And so, Jones, I think we can't emphasise enough formal systems of change are very important, but don't forget the social systems because they're so powerful in how work gets done. So there's lots more in this article, Jones, but that's a flavour of some of those proven strategies, which, well, I found it fascinating. I don't know if anyone else will, but I certainly did.
We also found it fascinating listening to you so that we don't have to read that article ourselves. So they were fabulous insights. Thank you, Balding. And we have another one. We have now the next article. We can pick out some good questions to ask to make sure you're remembering all the human beings involved in all of this. So the article is titled Achieving Greater Clinician Engagement and Impact in Healthcare Improvement, a Neglected Imperative. I think we agree, Balding, don't we, that it is a bit neglected?
Yes.
For sure. And this piece is from the Medical Journal of Australia, and it suggests a list of questions to ask before you start trying to make any change happen. So when you're preparing to tackle practice change, for example. So I've got a few of these questions for you, Balding. Let me ask them to you. And starting up, what is the quality and safety issue we want to address? What is the practice variation we want to address? And what's our goal? But then very quickly, who are the key stakeholders? And I think this is a really important question. What do they do? What matters to them? So you've got to get the what matters to them. It's really important. What drives their behaviour?
There's the meaning. There's the meaning, Jones. Yep.
So then another question, what are the key behaviours we may want them to change? And can we identify some individuals who are predisposed to or can help lead the change? So I guess that's the more traditional find the champion, and that will help, the champion of change. And this one, though, I think is the best question. How can we provide this kind of safe environment where people can tell us what they think about the change constructively? They don't have to hide their opinions. They don't hide their resistance. But it helps to increase common understanding, the rationale and the relationships. So a safe space where people can tell us what they really think rather than going underground in their resistance, which so often happens, Balding.
That's why resistances do occur underground, is it not, Jones? Because it's not safe above ground. I think this is just critical and something, once again, that we don't think about enough. It's a lot to talk about your practice in relation to others, particularly if your practice needs changing. So a safe space is critical. I would spend a lot of time building that safe space.
Yeah, definitely. And so this particular article also just sort of says, before you start to just think about, first of all, how are you going to measure this? So measure it, measure the baseline, and think about how you're going to measure your outcome and measure your change. So that all helps with the clinician engagement, but there's also a list of questions here for operationalising the change. I'm just going to pick out the ones most related, Balding, to engaging clinicians in this. And when you're trying to get the change to happen, it's, does the intervention emphasise enablement? So making it easy for people to do the right thing and hard for people to do the wrong thing, rather than just rules which people may resist. So making it easy for people is I think, a real key there.
Yep, definitely. And we've said that, I think, many times, Jones, in the past, and we'll keep saying it, yes.
Yeah. And then what resources or support do we need to implement and test the intervention, including, this will be where, do you need the project officer to help, or can it be done on existing resources? And then how do you evaluate and refine that intervention over time to make sure that everyone feels listened to? So it's listening to those last few resistors who are still holding out, and they could really topple your entire project. So making sure people remain listened to, I think, is key.
Yeah, it is, Jones. It's one of the basic human needs, is to feel listened to and understood. So ignore it at your peril, people. I think these are great questions, Jones. Once again, it just keeps us focused on not jumping in, boots and all, but thinking carefully about our preparation, because that's going to set you up for a much better chance of success.
Now that brings us to the end of our theory and our too long didn't read or too hard didn't read articles. Now everyone needs to go away and do something with all this vanishing variation information and theory that we've covered today, Balding. So we'll get to that in a moment. Our call to action. This brings us to the end of our Vanishing Variation podcast and video cast. And in our call to action now, we're just going to take 1 minute or close to sum up and make sure everyone knows what to do next. So what is everyone going to go away and do next? This is a question for you if you're watching or listening. Literally, back in the office next week or at the clinic or the hospital, we're going to try with 1 minute, aren't we, Balding?
Well, we're going to try, Jones, a 1 minute call to action. I don't know if you and I have ever managed that, but let's give it a whirl. So the short answer is start. pick something from our Get Started list. And what do we have on that list, Jones, that we've been mentioning all the way through the podcast and videocast?
Yep. Well, I think it's something our clinicians are curious about, monitoring your data, making sure you're looking at your internal and external data. Where are you seeing, consistent variation? And in process or outcome data. That's an oxymoron, isn't it? Consistent variation. Where are you seeing recurring incidents and sentinel events that might relate to variation?
Absolutely. And Jones, we've got proms and prems. We've got stubborn things on our risk register that won't shift. We've got our clinical areas that are high volume, high cost and high risk. And don't forget seeking your wonderful health information manager's guidance about clinical variation in your organisation. And our extremely intelligent listeners and watchers, Jones, I'm sure can think of lots of other ways to get started, but that's just a few that we've discussed today.
Yeah, I think that's probably our minute. But before we finish up, we need to mention use the 6 steps in the user guide and use the atlas because they are really, really effective. And, make sure you are working on the most important part of your health service. If you're working in community health and your greatest area of intervention is drug and alcohol services or mental health services, stop there and make sure that that's the particular kind of area that you're focusing on too. Now, I think that's our minute up, definitely, Balding. Let's move on to the next segment. Some thinking music there for everyone because this segment is called Frequently Asked and Answered Quality Questions. It's our section, Balding. And thank you to everyone. Thank you to everyone who has already been asking questions throughout the chat.
Fantastic.
That's wonderful. Now, if you're listening to us or watching us on the February 16, the live broadcast date, we're staying on the line immediately after this session for about 20 minutes, as we mentioned, and we'd love to hear your questions, comments or tips for others. So stay tuned for our frequently asked and answered quality questions segment, our FAQs section. And if you're listening or watching the recording later, feel free to ask us your question on the noharmdonepodcast.com website. We're happy to answer questions there as well, aren't we, Balding?
We sure are, Jones. Looking forward to it.
Roy and HG, eat your heart out. What a really fantastic session. It makes me think that quality improvement is a team sport. We've got questions to now in only a few minutes, but can I ask you guys, at the coalface, it can be really hard work trying to make change, trying to reduce unwarranted variation. How do you sustain the enthusiasm?
Well, I might go first, Jones. I've been at it slightly longer than you. 3 decades I've been sustaining the enthusiasm. Not always 100% enthusiastic. Yeah, we all have our days. But I think a couple of things, Anne. What gets me and keeps me enthusiastic is I'm very focused on the end result, very focused on what we can achieve. I make sure that I remember the achievements that I have been part of because it's just so fantastic because you're changing lives and there's nothing better. So I think it's being really, really focused on what you're trying to achieve. And it's easy to lose sight of that. If all your improvement program is a big series of hows without the why and the what you're actually doing, trying to achieve, it can get very tedious. So being very focused and reminding yourself about the good things you're achieving, and then finding a network, even if it's just one other person in another service like yours, or even not like yours, but who you can call or text or email and say, I think I've lost the plot. I think I've dropped my bundle, and have someone to help pick you up, perhaps give you an idea for moving on to the next step, because it really is sometimes, some days it's just about taking the next step, because it gets hard. It's a hard gig. But I think being clear about your purpose, reinforcing that to yourself constantly, and having at least one other person, preferably more, who can help sustain that enthusiasm and just give you someone to have a bit of a vent to and get some good ideas from. Absolutely just so important. Jones, what do you think? Oh, I think have we lost Jones?
Do it too.
Has she fallen off? All right. Well, I'm sure she will be back. Yes.
So please keep posting questions using the purple icon. In the meantime, as I've got an opportunity, can I ask you another question? As you've matured over time, how much more do you ask questions rather than make statements when you're trying to understand a new situation? Often we go in with a preconceived idea.
Yes, and that's so true, isn't it? Look, I'd like to think I did over the years get a bit better at that. You know what happens, and everyone who's online will know this. Even if you're just starting out, you know your own environment. So you know the people in aged care can walk into an aged care facility, and in 10 minutes they've just got a feel for it. You know they've got a feel. This is good, or I might be a bit concerned. People in hospitals can do it. People in community health and mental health can do it. And I think for me, I can do that with quality. It's pattern recognition. So you can have a conversation, ask really not too many questions at all, and just get a sense of where people are at. And the one giveaway for me as to where people are at with their quality system is when people talk to me about doing quality. If people say, oh, Cathy, no, we're very committed to quality here. We do quality on Tuesdays. I immediately know that what we've got here is a big focus on the how and not enough on the what we're trying to achieve. And I think that with variation, we could easily fall into that trap of, oh, well, we know all about the best practice here and we know all about the people who are doing it and not doing it, but we don't know what to do about it. And so, you know, I think the successful people in quality are about taking action. Cathy, did you catch that question? Welcome back.
I'm not sure we've got Cathy.
I don't think Cathy can hear us.
Which is unfortunate.
All right, so the techs will keep working on that.
Yeah, I think Cathy's coming. Yeah.
Oh, good.
So is there any question that you want to highlight? You've got a lot of questions that you're busy typing away during the session. Is there something that you really want to expand on from the presentation?
Oh, look, Anne, I think it can seem overwhelming, and I do want to acknowledge there's an awful lot in that. You know, when I watched it back for the first time, I was overwhelmed. Yeah. So I don't blame people if they're out there thinking, oh, this is for someone else. I can't cope with all of this. What we were trying to do really was give you quite a comprehensive picture in an hour. But as we say at the end, just start. Take one step. Maybe it's one conversation you have with a friendly clinician who might think, yeah, I wouldn't mind having a look at my practice against best practice. Maybe it's the chair of your board quality committee and saying, I think we should allocate some time to talk about how we could do this here. Just take one small step because that will get the ball rolling. And then once the ball is rolling, you can come back and look at the rest of this series, all the great stuff that's in it, and pick out the things that you need to progress a more systematic approach. But take a step. I mean, let's face it, I'm not a person that ever says do things for accreditation because that gets us into all sorts of trouble. But one good lever you have with your exec or your board quality committee is it's a standard. So it's an easy way to start a conversation. Look, this is something perhaps we haven't done much of before. We have to do it, but it's also got tons of benefits. So let's take a first step. So that would, out of all this, Anne, that would be my advice. And I think Cathy Jones, if we ever see her again, she may have disappeared into the ether, unfortunately. Cathy would definitely agree with that. And yeah. You know, Cathy's now working in aged care, and that's exactly what she will be doing with this, taking that first step and looking for where that is in her new organisation.
Brilliant. You got a lot of questions during the session and some fantastic questions there. Anything there that really you want to expand on? It's such a variety.
just let me have a quick look. Yes, thanks, Mary, for the reinforcement about quality being done. Yes, it's a real warning. Rings a big warning bell, doesn't it, when people say that? But there's still plenty of people saying that. Look, I think that the change aspect, Anne, is probably the challenging one. It's really hard, let's face it. If change were easy, we wouldn't be having this series, really, would we? Everything would be great. I'm a great believer that anyone who works in an improvement role or has a quality leadership type role must invest in some good change training. It is well worth it. It will repay you 1,000,000 times over. We come from, I think, in healthcare, with our beautiful hierarchy. Well, if we just change the policy and procedure and then give people some training and tell them they have to do it, well, what else is there? And of course, we know that change is just a little more complicated than that, particularly if you want to embed it and spread it and sustain it. So I would say at the root of all of this is good change, also some good statistical analysis. So when you're doing your problem definition, you're doing your analysis, you're not jumping at those shadows. You're saying, well, we got a problem with these results. We're just nowhere near where we want to be. It is, we can see from our analysis, it's definitely a variation problem. Or it's not, But good analysis, good change, I think, are at the absolute heart of any good improvement, but particularly with variation.
Hey, Balding, I'm back again. Sorry, I had to exit. It was a computer problem. Jones here.
So, Jones, did you want to pick up on anything Anne was just saying? Was there anything that anyone asked that you wanted to emphasise, take the opportunity now to emphasise or reinforce?
I think it's, again, just the fact that sometimes with variation we can blame individual people because, it's sort of a bad apple kind of approach to variation, and it's so rarely or almost never the case that is so. It's always a system issue whenever there's some variation happening. And I think I like the idea that we shouldn't be blaming our naughty clinicians because they're absolutely doing their best. And I think we made the point in the presentation as well. It's really difficult to change practice of many, many, many years and suddenly be told, nope, that's no good anymore. You've got to do it another way. That's very difficult to cope with. So it's making sure that the system is set up around everybody to help them reduce the variation, and quite often it's just communication of the data that helps people to do that and make up their own mind about it too.
Sometimes it's
Jones,
a long.
Oh, sorry, Anne, you go.
I was going to say sometimes it's a long haul. How do you maintain the interest in change? Humans like to sort of jump from something of interest to something else, and you really want people to bring people on for quite a period of time. Do you find that can be a challenge? And have you got any tips to keep people going when, particularly sometimes it's pretty hard work?
I'll take this one, Jones.
Yeah, sure. I mean, I think it's really important to stay upbeat when you're talking about change. We so often go in and say, you're not following the procedure, you need to follow the procedure. And I had a couple of emails today which were very much just, if you just follow the procedure, it'll all work. And rather than trying to think about why aren't people following this process, what is the reason behind it, what's the why or the reason for that particular individual, and trying to keep chipping away at that, I think, is really difficult. But you need to stay positive that people are trying to do the right thing, and keeping an upbeat approach, which sometimes isn't easy when we feel like we're constantly finding problems. So it's definitely not easy, I don't think, Anne. It's a certain difficult skill set that we really need to facilitate in our quality managers in particular, but in all of our healthcare workers.
I think too, going for as close to real-time data as we can get. We're a ways off that, but people just love to know what happened last week or yesterday. Now that's a hard thing to do, but if we're just working on one topic and you just found a way to collect some real-time data, perhaps as people were doing as part of an audit, if people are doing it at the bedside or the chair side or in an interview with someone where you're already collecting data, and add that thing, whatever it is, whatever issue we're looking at. It might be talking to a consumer and trying to decide between two pathways, or it might be looking at whether a person went to that test and had it when they were supposed to have it, or they didn't because someone out of the blue decided they didn't need it, and trying to pick up on those things. People love real-time stuff, and and the more we can work towards that, I think the more interested people are. I mean, we need long-term data for trends and whatever, absolutely, we don't throw that out, but I find that people are kind of curious when they know next day's results are coming, and I think we only need to look at a certain pandemic to have that reinforced.
Yes, true. There's a lot of enthusiastic junior clinicians out there. Are we tapping them? Should we do more to tap them? What's your experience? Because they're in some ways have that open-mindedness of seeing things and wondering why things are the way they are.
Jones, do you want to take this from your experience?
Yeah, I don't think we are tapping them enough, actually. You need to make sure that those are often the people that can see the flaws in the way we've been doing things for some time. If we've been stuck in a bit of a rut of doing our processes and in a certain way, it's the junior clinicians that will really embrace some of that change. So I think it is really important to not dismiss what sometimes more junior clinicians will say when they have a good suggestion about reducing variation or any other kind of change or improvement. So I think that's a really good idea. Whoever suggested that is on the right track.
Fantastic. Now,
Jones, sorry, Anne, I was just going to say there is a question there about access to data. Jones, if you have a look in the chat.
I'm out of the chat. You'll have to read it to me.
Yeah, okay. So this was from Scylla, I think. Let me just, Scylla says, this has motivated me to look into our data around metabolic screening and mental health. Fantastic. One barrier is that I don't have the right level of access to look at data and rely on others, and reports aren't easy to generate. Each time I go to investigate, I hit this block and then I lose a bit of will. What's your thinking about getting access to data, Jones?
That sounds like a leadership issue, so you're going to need someone a little bit higher up than you to agree that this is a useful activity and a useful project. So that's, I think it comes back, Balding talks so often about making sure that the senior leaders are on board. So if this is a quality activity that can be prioritised, you are going to have to get someone who can approve that data and persuade them that it's going to be a good idea to look at it. So I think it is really tricky when you don't have access to the right tools and information. I think someone else in the chat was talking about statistical process control, and most of our staff just don't have the mathematical skills to use those charts, even if they were available. So I think it's upskilling in that way is also really important.
And I think too, as I said, this is one of those occasions that I would say we have to do it for accreditation. That might open a few doors for you, Scylla. I think our question time is up, and unfortunately.
It is. I was going to give you a chance to say one last thing if it's short and snappy. Otherwise, we really have to wind up. And I think we should. But the good thing is, I believe you can go to your podcast website and plant a few questions. I think the good thing is that your session is going to be on the websites and on the Commission's website. So we can't take you home in our pocket, but we can certainly take you with us when we have to do a presentation, because you say things so well that I think it'll be fantastic to get the message out to so many people. And I can see people taking just even a short segment of your presentation and presenting it at their next meeting, because it's just such really valuable stuff. So it leaves me to thank you both of you very much for a fantastic presentation. I would like to thank everybody who joined us online, and particularly those who posed questions. I want to encourage anybody else who wants to ask any questions to either ask Balding and Jones or the Commission. If you want to get CPD points, then as well, think about that. I'd like to also thank our steering committee who have helped us get to where we are with our Webinar 5, and also the Commission team who've done a great job behind the scenes, which is always a very important thing to do. So thank you, everybody, and have a great day.